I shall become Dr. Asmaa Metawe to give the last case study of this session, case number 8. Please welcome Dr. Asmaa.
Good evening, and the last piece tonight will be about a 29-year-old man who presented with a hyperpigmented lesion on his right foot that developed a year ago. The lesion was non-itchy, painless, with superficial crusting and rapid increase in size with color changes. Patient could not recall any history of trauma prior to the lesion, and recent medical history was within none. Physical examination revealed a somewhat well-defined hyperpigmented plaque that measures 1.3 by 1 centimeter. It had a regular border showing multiple shades of brown color, light to dark brown, with central crusting on the outer surface of the right foot. A wide and lymph nodes were examined and were not unlikely. So, differential diagnosis, what do you think? Anyone have any suggestions? So, our differential diagnosis: malignant melanoma, acral lentiginous, pigmented bowel disease, benign acral melanocytic nevus, plantar wart, verrucous squamous cell carcinoma, pigmented basal cell carcinoma, and tinea nigra. The endoscopy showed parallel ridge return as furrows remain relatively hyperpigmented, asymmetrical structures and colors, hyperpigmented lesion in form of stone mosaic irregular edges, little scaly surface, regular brown to black dots, surrounding lesion with the basal hyperplasia. The workup we did for this patient included a scan biopsy for histopathology and immunohistochemical examination, in addition to routine investigations in form of CBC liver function and renal function tests, and they were normal. Immunohistochemical examination: it showed positive staining for melanoma-associated antigens using the antibodies HNB45 and S100. Regarding the histopathology, the bristle depth of invasion was 1.4 millimeter. It showed architectural disorders including asymmetry and poor circumscriptionness of melanocytes of various sizes and shapes in lower epidermis and tendons. It showed atypical melanocytes that had a larger size, larger hyperchromatic nuclei, irregular nuclear shape, and nuclear polymorphism with abnormal chromatin patterns. Sentinel and cone biopsy of inguinal nodes was negative. So the final diagnosis of our case was acral lentiginous melanoma. Regarding the management, the patient was referred to the surgical oncology department. Inguinal lymph nodes ultrasound was done for staging. PET scan, chest X-ray, pelvic and abdominal ultrasound were also done to exclude any metastases, while local excision with sufficient septum margin was done for the patient. Acral lentiginous melanoma is a rare subtype of melanoma that represents approximately 5% of melanoma diagnosed each year. It's the most common subtype of melanoma diagnosed in non-Caucasian patients. Clinically, acral lentiginous melanoma is usually presented as a dark spot of skin surrounded by normal skin. Acral lentiginous melanoma spots may not always be dark or even dark at all. Some spots may be reddish or orange in color and called a melanotic melanoma. It is found on the bulb, sole, and subungular spaces. Lesions are typically larger than 0.7 mm in diameter and are irregularly shaped or asymmetrical with notching at the periphery. In contrast to other forms of melanoma in which UVB exposure is a non-risk factor for development of melanoma, the connection between UVB as a pathogenic driver for acral lentiginous melanoma is not as clear. ABCDE rule for melanoma is a helpful tool for determining whether the lesion is suspicious. ABCD rule for early detection of melanoma: A is referring to the asymmetry, B border, the outer edge are uneven, C for color, dark black or have multiple colors, D for diameter, which is greater than 6 mm, and E for evolving, that means change in cell size, shape, and color. The distinction between benign acral nevus and acral lentiginous melanoma may be facilitated with utilization of dermoscopy. Definitions of dermoscopic criteria for 3 points checklist: asymmetry, which means asymmetrical distribution of colors and dermoscopic structures; atypical network, pigmented network with irregular holes at the flanks; no white structures, any type of blue-red or white color. Diagnosis of melanoma when all three criteria are met. Suspected melanoma when lesion meets one criteria. Histologically, acral lentiginous melanoma often displays a lentiginous growth pattern with nests of melanocytes, arranged in lines along the basal line of epidermis at the dermal-epidermal junction. Vegetal display may be absent in every stage and is known to occur later. Vertical growth phase may also exist in some cases of acral lentiginous melanoma, and histologically one would expect to see a central plaque-like thickening of malignant melanocytes extending into papillary dermis, with concurrent dysplasia of spindle cells, epidermal hyperplasia, and elongation of retinages. Vertical growth phase may be visualized clinically by an angular component to the lesion. Early stages of acral lentiginous melanoma are generally curable. It will be treated with white local excision with sufficient CT margin based on tumor thickness at time of biopsy, after exclusion of affection of any sentinel lymph node. However, delayed evaluation and diagnosis not always yield such favorable results. For patients with advanced stage disease who has a deeper level of invasion, lymph node may need to be removed. Amputation of digit may even be necessary. If there is evidence of metastasis, systemic treatment with chemotherapeutic agents, targeted mutational therapy, and immunotherapy will be required. Take-home message for today: any pigmented lesion that demonstrates significant change should be examined to exclude melanoma. Early detection and management offer the best chance of cure. Thank you.